Good morning, good afternoon, good evening, wherever you are. Welcome to another emergency questions and answers for families in intensive care and intensive care at home. My name is Patrick Hutzel from Intensive Care at Home and intensivecarehotline.com, and I want to welcome you to today's emergency questions and answers for families in ICU and intensive care at home. I also want to welcome our viewers on replay, because I know we've got quite a few viewers that watch this on replay. Before I go into today's questions, what makes me qualified as the host of the show to answer questions for families in intensive care and intensive care at home? Once again, my name is Patrick Hutzel. I am the founder and managing director of intensivecarehotline.com as well as intensivecareathome.com. I am a critical care nurse by background, and I've been working in critical care nursing for over 25 years in 3 different countries. And I have been consulting and advocating for families in intensive care as part of this since 2013 here at intensivecarehotline.com. I also worked as a nurse unit manager for over 5 years in critical care nursing, and I've been consulting and advocating for families in intensive care since 2013 here at intensivecarehotline.com. And like I said, I can confidently say we have saved many lives for our clients in intensive care, and you can verify that on our testimonial section at intensivecarehotline.com, and you can verify it on our intensivecarehotline.com podcast section, where we have done client interviews. I'm also the founder and managing director of Intensive Care at Home, and you can find more information at intensivecareathome.com. With Intensive Care at Home, we're currently sending our critical care nurses into the home 24 hours a day. All around Australia, we're providing a genuine alternative for a long-term stay in intensive care and critical care, predominantly for long-term ventilation and tracheostomy, but also for ventilation without tracheostomy, tracheostomy without ventilation, home TPN, home IV potassium infusions, home IV magnesium infusions, PEG tube, nasogastric tube, patch tube management, cough assist management, central line management, Hickman's line management, PIG line management, as well as portacath management at home. We're also providing level 2 and level 3 NDIS support coordination for intensive care at home, and we're also providing TAC and WorkSafe case management. Now, without further ado, let's dive into today's questions that have come in during the week. But in the meantime, send your questions into the chat pad, or connect with me live on the StreamYard link. You can talk to me directly if you go to the link that I posted in the chat pad, and you can talk to me directly on or off camera, doesn't matter to me, but you're welcome to talk to me. Okay, let's start with another testimonial that came in this week from Karen, who says, "Hi Patrick, it's been 3 years and I always share with everyone how Patrick and intensivecarehotline.com saved my husband's life. My husband Tom had just completed treatment for cancer when he then contracted COVID. He was ventilated twice, hospitalized for 4 months. A nurse told me to take him off the ventilator because his quality of life was so horrible that a nursing home would not take him. He went into the hospital at 3 p.m. at the 8th of January and came home on the 2nd of February, unable to stand, eat, and had a stage 4 wound. But he went back to teaching for 2 years and is retiring. Upon his retirement, I know he is a miracle and fighting. Patrick and intensivecarehotline.com helped save his life. He was able to dance at his son's wedding because of Patrick and intensivecarehotline.com. got to see another son graduate from military band boot camp. Thank you, Patrick, and intensivecarehotline.com. I will forever and ever be grateful for your care and wisdom. From Karen. Well, Karen, thank you so much for sharing that with me and my team, and obviously giving me the opportunity to share it here on the podcast. I am not exaggerating when I'm saying we have saved many lives for our clients in intensive care because of, our intensive care insights, because of our advocacy, because of what we do for our clients, because of giving patients and families a different perspective away from the often one-size-fits-all approach from intensive care teams. And, you use good judgment with, a nurse telling you, oh, we should just take your your husband off the ventilator and let him die because he wouldn't have any quote unquote quality of life. Like I always say, quality of life is subjective. Not only is quality of life subjective, it's also something that can't be quantified. What is quality of life? And sometimes patients do get better over time, sometimes they don't. But even if they don't get better, that doesn't necessarily mean they don't have quality of life, right? You cannot measure quality of life. You can only measure subjective quality of life, and that is what it often comes down to the subjectivity of someone perceiving quality of life as good or bad. In some situations, it's quality of end of life. Patients want to die at home. Patients want to die at home. And that is the bottom line. But in this case, it was a case of going back to work. It was going back to their son's wedding. Seeing their son graduate from military band boot camp, whatever it is. Imagine this family would have given up, right? Imagine they would have given up, would have just given in. Unfortunately, her husband would have been another casualty instead of success story. There's a fine line between a casualty and a success story, as you can see. Clearly, there's a fine line. That's what I'm saying. You always need a second opinion, right? The biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. That's exactly what this family recognized and got some help. So thank you, Karen, for seeing things for what they are, and that you did get a second opinion. You saw things for what they are. You obviously recognize that you can't and don't want to trust the intensive care team with their opinion. That is why you got help, got professional help, got advocacy, and therefore your husband got best care and treatment. And you had influence, you had power. I remember working with you, but you were also implementing things. You didn't question them. You were just running with them. You were running with them and you were implementing them. Very important. The minute you are timid, the minute you are intimidated by intensive care teams, that's the minute when you drop the ball, when you lose all control, right? So you've done a great job here, Karen, by also empowering other families here, that are watching this. You've done an amazing job, right? So who would have thought that, from going from, being told, oh, your husband won't leave, and if he does leave, he won't have any quality of life, going back to work, going back to teaching, going back to, spend time with family is, a great achievement. It is a fantastic achievement. And it should encourage anyone on this call, that has a family member in intensive care in similar situations where they are told, oh, my loved one should just die. They want to pull the plug. to give it a second thought. I mean, pulling the plug is often illegal without patient or family consent. It's very often illegal, So go with your gut and go with whatever you need to do to save your loved one's life. One thing to recognize as well is whether your critically ill loved one is in a real or in a perceived end-of-life situation. So what do I mean by that? A real end-of-life situation is a situation where your critically ill loved one, a real end-of-life situation is where your critically ill loved one is in intensive care and they're going to die. No treatment, no surgery, no equipment, no medications, no nothing is going to save their life. That's a real end-of-life situation. A perceived end-of-life situation is a situation where there's a perception that someone is dying. And often when there's a perception, the ICU team is trying to wind down things for them, right? And you need to counteract that. You need to recognize it for what it is. If you're not recognizing for what it is, you are doing your family member a disservice, and your loved one might die because you're not recognizing that they're in a perceived end-of-life situation and not in a real end-of-life situation, right? So you need to recognize the difference. Next, look at the statistics. Approximately 90% of intensive care patients survive. That's 9 out of 10 surviving, meaning most patients the overwhelming majority of patients in intensive care survive. Now, there are different statistics out there. I recognize that. Some statistics say 70%, 80%, 90%, but the best statistic that I've seen is about 90%, right? So that should make you think, or give you the confidence to know that your loved one's odds are in their favor. So what makes you think that your loved one won't survive if the odds are in their favor? That's how to approach it. The glass is half full, not half empty, right? So those are very important statistics, and the ICU team does not want to tell you those statistics, but you must know those statistics clearly. It's imperative for you that you know those statistics, and that you do know the difference between a real and a perceived end-of-life situation. You must know the difference. And you must know that quality of life cannot be objectively measured. Quality of life is something that is entirely up to you and your family to measure and to make a judgment about. It's not for intensive care teams to make, right? It is not for intensive care teams to make, right? It is entirely up to you. And your husband was in ICU for 4 months. That's a very long time. But was it worth the fight? Was it worth the persistence? Every minute of it. Every minute of it. And you need the insights from insiders that have been there, done that, seen it many, many times. How do patients survive in intensive care? What needs to be done? How to not buy into the doom and gloom. I want to give you another email as a warning, actually. I want to give you another email actually as a warning that ties in with today's topic, because where's the email? It's quite a disturbing email, but I do believe, you need to understand what we're dealing with. Yes, so there was an email from Jamie who says, with a violation in HIPAA and the emergency guardianship granted, the agency that was granted guardianship of my father pulled his plug. He passed away at the hospital along with no one at the bedside. From Jamie. This is someone we've been emailing back and forth, but never became a client, but again, If you're not taking action, that is what's happening. So obviously a hospital must have taken emergency guardianship for, you know, an overseeing agency, and they pulled the plug. You know, that's terrible. And it is also important for you to understand that you need to have your paperwork in place for guardianship, for power of attorney, and so forth. Because if you're not, this is what might happen. Very rarely have I seen it happen, right? But most of the time, as long as you have your paperwork in place, you are the one calling the shots, not some third-party agency or even a hospital, you know, because that would be very detrimental to everything, right? So you have to be one step ahead, not lagging behind, because if you do lag behind, that is once again exactly what's happening. You know, Karen was one step ahead and also knew initially that she was more than one step behind, which is why she was asking for help. You need to recognize the things that you simply don't know and where you need help. You know, intensive care is a complex puzzle to solve. It comes down to, you know, understanding all the nuances and then putting together the picture that emerges, right? It's about understanding treatment options. It's about understanding how intensive care units operate, what's important for them. What is important for them often is bed management, resource management. I didn't say patient management. I said resource management, bed management. You know, and patient management can be important too, of course, but you know, most ICUs under resource limited, under resource constraints. That is just the bottom line. ICUs are resource constrained, right? Okay, so let's move along from here. Now, yesterday I had a phone call from a lady who says, I said, oh, I only need 2 minutes of your time to answer a question. And I said to her, look, most questions that families ask in intensive care take more than 2 minutes because, you know, it is, generally speaking, such a complex situation. So here's the question she had. She said, her husband's in intensive care with a ventilator and a tracheostomy, but she said he's getting substandard care, right? And because he's getting substandard care, she asked whether she could send him to another hospital. And I said, yes, she absolutely can. And she asked, can I get him to my car, sit him in my car, and drive him to another hospital on a ventilator with a tracheostomy? And I said, well, in theory you could, but chances are that your husband will be dying on that trip because he's on a ventilator with a tracheostomy. And that is basically life support, right? For patients on life support, you can't just put them in a car and hope for the best. If the ventilator becomes disconnected, if the tracheostomy blocks, if the tracheostomy comes out, you know, patient could die very, very quickly, right? So I said to her, yes, your husband can be transferred, but shouldn't be transferred in your car, because that could be very detrimental to your husband. Could be, as a matter of fact, life-threatening, of course, you know. So what should happen in a situation like that is clearly your husband should be transferred to another hospital safely via road ambulance, or maybe by a helicopter. She didn't say, you know, how far away the other hospital would be. It sounded to me like she had a plan in terms of where she wants her husband and so forth. But this has to be thought through. Now, bearing in mind, transferring a critically ill patient from one intensive care unit to the other intensive care unit is not that difficult. You know, patients are being flown around in helicopters, planes, road ambulances to go to other ICUs. That's happening all the time, all over the world. So, you know, with specialist crews, you know, that's definitely possible. But keep in mind, it needs to be well managed, it needs to be planned, and it needs to be well thought through. and not at the spur of a moment, right? So we have helped families to go to other ICUs, whether that's in other ICUs, in the same town, whether that's in other ICUs, 2 hours away, including we've helped organize a flight to Beijing from Melbourne at the time for a critically ill patient on a ventilator with a breathing tube, right? So this is all possible, but there's obviously ICU doctors then, there's ICU nurses, there's paramedics, there's special equipment on a plane, to make that happen. So it's not as simple as just saying, oh yeah, we're going to another ICU and we'll do it now. That's not how it works. That is not how it works. So all possible, but not in your car, because you wouldn't know how to deal with a medical emergency if there was a medical emergency. You can't risk your husband's life in a situation like that. You cannot. That would be futile. That would be absolutely futile. So I hope that helps you understand what you need to do when it comes to a transfer from one ICU to the other. It is not straightforward, and it needs to be planned. Needs to be planned almost religiously. Needs to be planned in much, much detail. And whilst I understand that, you are probably very frustrated with the care that your husband is getting or not getting potentially, have you made a complaint? Have you spoken to them? Speak to them first. And maybe you have. It was a reasonably brief conversation. I think this lady was looking for a quick fix. And unfortunately, there is no quick fix here. It is something that needs to be planned very, very strategically and not rushed. Okay, can't be rushed in a situation like that. So I hope that helps you understand what needs to happen when it comes to planning around transfers from one ICU to another. Like I said, all doable, but not in a hurry. Do not do that in a hurry. It'll be causing more harm than good. Okay, let's look at another question that has come in during the week from Archie, who says, "Hi Patrick, my grandmother is in her 80s. Last Tuesday, the ambulance was called. My grandma couldn't breathe. They said she flatlined for 10 minutes, so they did a brain test, and a miracle, no brain damage yesterday. 7 days later, she started to open her eyes and squeeze her hand, and she showed tears. I'm fighting for her. I don't know what to do next. They want her to breathe on her own. The machine was at 51%, now it's at 40%. Please advise." Well, the good thing here is that your grandma has no brain damage and that she's still alive. So that's a good thing, right? And that's a lot to build on. Now, if she's still ventilated, assuming with a breathing tube, you have every reason to fight for her. So here's what needs to happen. She needs to be weaned off the ventilator. She needs to be taken off all sedation, all opiates, anything that makes her drowsy, keeps her sedated or sleepy. And she needs to start breathing up. She needs to start physiotherapy. She needs to get mobilized. She needs to do breathing exercises, and then gradually the ventilator settings need to be reduced. Now that needs to go hand in hand with checking arterial blood gases. It needs to go hand in hand with reducing ventilation support, needs to go hand in hand with chest x-rays, needs to go hand in hand with, keeping, checking, you mentioned asking you to squeeze your hand, poking out tongue, wiggling toes, asking her to do more and more so you can always check in that her brain is working, doing breathing exercises, doing coughing exercises. Ideally, get her out of bed. Strengthen her breathing muscles as quickly as possible, especially for elderly patients. Especially for elderly patients, it is important that they get back moving as quickly as possible, because otherwise the risk for deterioration, for muscle wastage, for deconditioning is very high. And then it takes longer for patients to bounce back, because if she's been ventilated now for about 7 days, at about day 10 to day 14 mark of no progress or the inability to wean off the ventilator, the conversation often starts to happen around tracheostomy, whether tracheostomy is the right next step, because a tracheostomy can, be, the breathing tube can be removed if a tracheostomy is put in the neck and connect the ventilator there. But that must be a last resort. The first resort must be to try and extubate your mum, to get her off the ventilator as quickly as possible and try to extubate her, right? And I've just mapped out some steps. Why did your grandma not open her eyes until 7 days later? Is that because she was sedated? Or is it because she does have some brain damage, right? Sounds to me like brain damage has been ruled out. So if she's not waking up until day 7, she has been off sedation. Why is that? If she is still on sedation, she needs to get off it. Otherwise, she cannot breathe up properly, right? So what are the steps to get your grandma off the ventilator? Once again, take off sedation, do mobilization, do physical therapy, do arterial blood gases, and then reduce the ventilator settings gradually. Let's just say she's in a controlled ventilation mode at the moment with a rate of 16 breaths per minute. Reduce the rate step by step, right? Reduce the rate step by step, maybe turn it down to 10, and then hopefully she can breathe up. If she can breathe up, turn the rate down further. Turn the oxygen levels down further. You said it's now at 40%. Please keep in mind that room air, the air that you and I are breathing, is 21%. It needs to, the oxygen levels on the ventilator need to go down to as close to 21% as possible, right? So if that can be achieved, respiratory rate can be turned down, your grandma is breathing up, breathing independently on top of the rate she's getting from the ventilator, reduce oxygen, reduce PEEP, reduce pressure support, then get her to breathe in CPAP or on a spontaneous pressure support mode, right? And again, check arterial blood gases that they're holding up. Make sure your grandma stays awake. Make sure your grandma's not getting exhausted by breathing spontaneously on CPAP or on pressure support. And if she can go through that phase as well, then it's time to look at pressure support. Shouldn't be any higher than 8. FiO2 shouldn't be any higher than 30%. Make sure arterial blood gases are maintained again, that they stay within normal limits. And then, do a spontaneous breathing trial, i.e. take your grandma off the ventilator completely and see how she goes with that. If she goes fine with that, and she's still obeying commands, arterial blood gases are still good on minimal ventilation support or after passing a spontaneous breathing trial, then she should be able to be extubated. So that is what you should be fighting for here. That is your best case to fight for, right? And then, get her out of ICU as quickly as possible. That's also very important. You don't want her in ICU for any longer than necessary. That is really very important. And you mustn't underestimate the importance of mobilization. You mustn't underestimate the importance of ventilation and mobilization, because that goes hand in hand to wean off ventilation, right? Very, very important. Okay, let's move on in regards to an intensive care at home question, or intensive care at home questions that have come in during the week. Just finding the email here. There it is. Okay, so we're currently talking to an ICU as well as to a family to get their loved one home from ICU after about 6 weeks in ICU after a car accident, right? Patient is ventilated, has a tracheostomy, and is unable to wean off the ventilator and the tracheostomy, but wants home care. Patient is elderly, has been in a severe high-speed motor vehicle accident, and is, wants to go home. At the moment, she can't be weaned off the ventilator, which is why, family has reached out to us. It looks like it's an insurance commission case, i.e., after motor vehicle accident, the insurance should kick in for home care as well. We are looking after other home care clients. So let's look at that. Let's look at the questions that have come in there from the ICU actually. And for anyone watching this, if you are working in an ICU and you want to know more about our services, is a good opportunity to answer some questions here. So the ICU is asking, what about the tracheostomy and PICC line change every 30 days? Who would facilitate this? So we can change tracheostomy at home, and we are doing tracheostomy changes at home, whether they are elective tracheostomy changes, and God forbid sometimes they're non-elective, but the non-elective ones happen very rarely. They still happen every now and then. So that's how we deal with tracheostomies at home, unless of course there is a super high risk where a tracheostomy change needs to happen in a hospital environment. I'll give you an example. When a tracheostomy change does need to happen in a hospital, there's one client that we have worked with over the years. The tip of the tracheostomy is sitting very close to an artery, and in the past, even with a tracheostomy change in a hospital, the artery started bleeding. Obviously, that is a very high risk, and therefore a tracheostomy change for a patient like this ideally needs to happen in a hospital or in a controlled environment. Sometimes it needs to happen under bronchoscopy, but that is the exception, not the rule. With PICC lines, no, we cannot change PICC lines at home. That would need to be done as an outpatient, but PICC lines do not need to be changed every 30 days. PICC lines can stay in for up to 12 months. Right? We have certainly had clients at home with PICC lines staying in for up to 12 months, predominantly for home TPN, but also sometimes for IV potassium, IV magnesium infusions, but they can stay in for up to 12 months. Next question that came in: how does ongoing management of a patient like this look? So first off, because it's through a car insurance scheme, the car insurances or the motor vehicle insurances scheme, they have often their own case managers, right? Because they then usually allocate the funds to service providers in the community, whether that's obviously to intensive care at home, whether that's to allied health, such as physio, OTs, but also medical, but also auxiliary support, such as support workers to support 24-hour critical care nurses at home. So that's usually the process. That's how it works with the TAC in Victoria, iCare in New South Wales, and IISQ in Queensland. This is obviously a different insurance scheme. I'm not going to mention names, but it's sort of a similar process. We obviously provide the 24/7 nursing care with critical care nurses with a minimum of 2 years critical care nursing experience, similar to many other clients we're currently working with that are ventilated with tracheostomy. And with all of our clients, there's always a multidisciplinary team that needs to be created before discharge home. And once again, whether that starts with the nursing care, the medical cover, allied health, physio, OT, speech, dietitian, and so forth. And then often there are, at least for parts of a day or a night, there are support workers as well to help with turns, help with pressure area care, but also help with household tasks sometimes, because they can't be done by the nurses because the nurses are busy with nursing the client. The other question that came out of this is, what's the escalation protocol? Well, escalation protocols, first of all, depend on the goals of care for a client, right? What are the goals of care for a client? Is it to wean them off the ventilator? Is it to provide palliative care at home? What are the goals of care? And the escalation protocol will be tailored around that. Now, whilst we have a standard escalation protocol, that is if there are no treatment limitations, if it's a straightforward ventilated tracheostomy client and there are no other issues. So, but it's not necessarily, well, it actually very rarely is a one-size-fits-all approach. Every client has their unique parameters, really, about when to escalate treatment, when to escalate care, but there is always an escalation protocol. If not, it's our standard protocol, but a lot of it really comes down to understanding the client's situation, the client's condition. Goals of care, like I said in the beginning, goals of care, care plans, right? Rehabilitation plans, those discussions need to happen to then have an appropriate escalation protocol or policy. Another question that came about is turns, pressure injury concerns. Again, like I said in the beginning of this call, where one of our other clients had a question around, is 2-hourly pressure area care something that they can expect? What if it's not 2-hourly? What if it's over 2 hours and there are pressure sores and the ICU is not informing families? Well, like I said, during that segment of the call here, that's gross nursing and medical negligence, full stop, right? And because it's gross nursing and medical negligence, that's not good enough. But we do the same at home. We turn our patients to hourly if they're not mobilized and if they're not out of bed, right? Very simple. They're not out of bed and if they're not mobilized. Next, rehabilitation goals. But once again, what are the client's rehabilitation goals? Like, can that be done at home? The goal is to get this lady off the ventilator, of course. Can that be achieved? I don't know. I don't have enough information just as yet. But, these are questions that have come from the ICU directly, but we haven't actually been given a full picture of the patient. Whilst we know a lot, it's not a full picture. We haven't been able to look at medical records, for example, to give us an idea of what's happened to this point. Whilst we have a good idea from the family, it's probably not enough to talk about rehabilitation goals just as yet. Then the question came up about legal governance, who's responsible? Well, Insurance Commission in a situation like that, as the funding body, once again will allocate service providers that have their own legal governance, i.e., we have our own legal governance, intensive care at home, then allied health providers such as physio, dietitian, OT, speech therapy, and so forth. They usually have their own legal governance because we don't employ them. We are solely responsible for the nursing care, right? But the Insurance Commission also has a responsibility about putting the funds in place, putting the service providers in place, making sure the client gets what they need and what they're entitled to. Then next, who's the doctor overseeing a case like this? Well, that's a great question. From our perspective, with all of our clients in Australia, it depends a little bit on the state. So, for example, in Victoria, for most of our adult clients, it's the VRSS overseeing the clients from a medical point of view. The VRSS is the Victorian Respiratory Support Service, and the Victorian Respiratory Support Service is overseeing the adult clients medically. If it's a pediatric client, ventilated client, they are overseen often by the Children's Hospital in Victoria, in Melbourne, right? So it depends a little bit on the clinical governance. In other states, like in Queensland, New South Wales, South Australia, WA, there is no such thing as the VRSS. So then the medical cover often comes through hospitals, can come through respiratory physicians, through anaesthetists, through pediatricians, sometimes even through GPs. But it can also come through one of our private intensive care consultants, right? We're working with private intensive care consultants as well. So, you know, those are the options. And it's never an obstacle, really. You know, as we all know, ICUs need beds. And because ICUs need beds, you know, that's why, you know, there is always a solution going forward to get patients home. Takes goodwill from all parties, of course, but, you know, that goodwill can be created, for sure. So, I hope that helps you understand of, you know, what needs to happen in a situation like that. So then another intensive care at home question we had coming in this week was, just give me 1 second, then I can bring up the email. Can a phosphate infusion be given at home via a central line? Well, that's a great question. And can intensive care at home do that? Well, that's a great question. Well, central line, PIC line, Hickman's line, border cath, we can manage all of them at home. It's not the issue. Now, does a phosphate infusion always need a central line? No, it doesn't, but most of them do. It can also be given via a big or a large peripheral vein, but the question also is it potassium phosphate or sodium phosphate, or is it, you know, which one of the two is it? Because potassium phosphate has a higher risk for vein irritation, and therefore it's much better to use a central line or a PIC line or a Hickman's line or a porter cath. Now, keep in mind, you know, depending on what's going on with electrolytes, for example, you know, if the patient needs a phosphate infusion, but then their potassium drops, for example, and they're getting sodium phosphate, right? That can be given peripherally. But what if it changes? What if phosphate needs the add-on of potassium, right? Then a central line would be so much better, because patients that receive potassium through a peripheral line report excruciating pain, right? Which is why it needs to be given through a central line. So that was a question actually from a hospital that came in last week, whether we can do that. And I said, yes, we absolutely can. You know, again, we're managing central line, PIC lines, Hickman's line, and porter cath at home. Right? That's what we do. It's part of our skill set. So, those were the questions I wanted to address today. If you have any questions, please type them in the chat pad, or click on the StreamYard link here and call and talk to me directly here. You know, talk to me directly. This is your opportunity. This is your opportunity to talk to me. All right? If not, if you don't have any questions, and I am going to wrap this up today, right? And like I said, with Intensive Care Hotline, if you need consulting and advocacy in intensive care, go to intensivecarehotline.com, call us on one of the numbers on the top of our website, or simply send us an email to support@intensivecare.com. We also have a membership for families of critically ill patients in intensive care, and you can become a member if you go to intensivecare.com, if you click on the membership link, or if you go to intensivecaresupport.org directly. In the membership, you have access to me and my team 24 hours a day in the membership area and via email, and we answer all questions intensive care related. I also do one-on-one consulting and advocacy over the phone, Zoom, Skype, WhatsApp, whichever medium works best for you. I talk to doctors and nurses directly. I talk to you and your families directly. Of course, I handhold you through this once-in-a-lifetime situation that you simply cannot afford to get wrong. We also do medical record reviews in real time, and we also do medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are suspecting medical negligence. With intensive care at home, like I said, we are providing a genuine alternative to a long-term stay in intensive care. And all around Australia at the moment, we're sending our critical care nurses into the home 24 hours a day as a genuine alternative to a long-term stay in intensive care, predominantly for ventilated and tracheostomy clients, adults and children. Okay, I am going to wrap this up. We're also providing level 2 and level 3 NDIS support, coordination. We're also currently hiring for critical care nurses in Melbourne, Sydney, Brisbane, Albury, Wodonga, Geelong, Warragul, as well as in Bendigo. If there are no other questions, I do wrap this up now. Subscribe to my YouTube channel, like the video, click the notification bell, share the video with your friends and families, comment below what you want to see next, what questions and insights you have. I do this weekly YouTube live that every Sunday morning, 10:30 a.m. Sydney, Melbourne time, which is currently 8:30 p.m. I believe, 8:30 p.m. Eastern Standard Time on a Saturday night. It is 7:30 p.m. on a Saturday night Central Time, North America. It is 6:30 p.m. Mountain Time, North America, and it is 5:30 p.m. Pacific Time. And it is, right now, it would be just 1 a.m. or 1:30 a.m. in the UK and Ireland. So watch out for these YouTube lives. They happen every week, same time. Thank you so much for watching. I'll see you again next week, and look out for the quick tips and other videos that I'll be sending through during the week on my channel. Take care for now, and stay safe.